Good morning.
Good morning.
How are you?
I'm good.
Nice to hear. Whew. Okay. Questions. Cats. Work is done though, so that'll be a done deal. And we have some really nice questions today, so it's always good to see you. And I'm welcoming everybody who's going to come on. And good morning, Kathy. And we'll get started. Yeah.
Yeah, good.
Oh, okay. Questioner says, I am a woman who has not had a full hysterectomy and going through menopause naturally. If one starts taking exogenous hormones, won't the body then stop making its own hormones and become dependent on the exogenous hormones forevermore? I don't want to ruin my body's own natural ability to make my own 30% of hormones by taking other hormones that will not be of benefit much to me. Then they're going to cost a lot. And then they're going to make me stop taking them anyway after X amount of time. And by that time, I could have messed up my whole body's natural ability to make any of its own hormones. Long question, I get it.
Yeah, but it's such a good one.
I know, huh?
Well, behind this question is the thinking that has some great relevance in other hormone issues. Like, for example, our thyroid glands produce two thyroid hormones, among other things. And it's common for people to go functionally hypothyroid. And this has been going on for 50, 75 years.
Right.
For example, it was very common for where I grew up in Michigan for the country doctors to be giving their patients desiccated thyroid.
Mm-hmm.
Our professors said, oh, that's not such good medicine. Our professors at the university, take them off that thyroid. And I would go to the patient and say, your country doctor doesn't really need to prescribe you this thyroid. And the patients would get adamant. And they'd say, don't infer anything about my country doctor. They've done more for me than you guys ever have. And I love this stuff. It makes a big difference in my life. That was my first introduction to thyroid. And there is an issue. Like, for example, if your own thyroid is producing, well, even less than optimal thyroid hormones, and you take an imprecise amount of thyroid hormone by mouth, imprecise is the key issue there. And the imprecise I'm talking about is too much thyroid by mouth. Our bodies have a way to protect us from these excessive thyroid dosages, and it will shut down our own gland. Thus, someone will be relying upon the oral thyroid hormones they're taking, exogenously as it's known, and shut down their own thyroid gland.
Ouch.
Now, no one who likes precise medicine is going to think that's a good thing. And I think the concern about shutting down our own glands really originates from the shutdown of the thyroid glands, or this was also done with corticosteroids, with cortisol in the 50s. Yeah, doctors gave patients cortisol, and patients loved it, and it got extremely popular. Why did patients love it? Because they were adrenal tired, you know? And not only that, cortisol gets people high, even excessive dosages. So people loved it. It got very popular. But the problem was that excessive dosages were getting given out. It got very challenging to wean these patients off these excessive dosages. More important, the excessive dosages of cortisol showed up by getting overdose symptoms of too much cortisol, moon phases, fat redistribution, get a buffalo hump up here, it was called, and immune system suppression. So this is a relevant origin. This is a relevant question.
Very much so.
And it comes from past learning experiences, shall we call it, in the world of treating humans with hormones.
Right.
Well, let's look at the ovaries, though. And as I've said on many occasions, the peak ovarian hormone output, we're talking estrogens, progesterone, testosterone, and DHEA, occurs about the age 20 plus or minus 2 years in all women. And from that moment on, hormones decline. So a 30-year-old does not have the same amount of ovarian hormones that she did when she was 20. And a 40-year-old has less, and this goes for males too. This is not exclusive to women. And then in women, there's a major decline when the ovaries no longer produce any hormones. And that's where menopause, period stop, and menopause begins.
Right.
Now, that decline is going to take place. It does in everyone. There's no stopping it, as far as I can tell. There's
Right.
no method to encourage the ovaries to keep going, keep producing it. And even our own women's bodies tries to keep the ovaries going. Near the perimenopause, the pituitary gland and brain will go, uh-oh, the estrogen's fallen too low. Let's see if we can put out some increased amounts of a pituitary hormone called FSH, follicle stimulating hormone, that will raise the estrogen. And, indeed, it works sporadically. A woman's body produces some extra FSH. She'll get a little burst of estrogen out of the ovary, but the ovaries can't keep it up because they're going to stop producing ovarian hormones. That's the certainty. That's been going on since the dawn of humankind.
And so that is definitely natural,
yeah,
right?
So to speak. And then the issue becomes, well, if anywhere along the line, if a woman starts taking hormones in addition to what her ovaries putting out, is she going to suppress her natural ovary production? That's not being done very commonly, because even women in their 30s and in their 40s, some of them are actually picking up on the symptoms of insufficient ovarian hormones and actually going to providers to see if they can do anything about the symptoms of ovarian hormonal insufficiency that they're getting.
Mm-hmm.
Dry vagina, urinary tract symptoms, among many others, cognitive issues, lost libido, no more vaginal lubrication, and stuff that they don't see. The bones are losing it. The muscles are losing it. It's all kinds of things. Download Happy, Healthy Hormones, and we go through the whole list of what happens from the decline of ovarian hormones. Well, even if a woman picks up on it enough and actually is motivated enough to go to someone knowledgeable, a healthcare practitioner knowledgeable in treating low ovarian hormones, it's unlikely, with exceptions, that they're going to be put on excessive dosages.
Okay.
Certainly in the menopause method, all of our providers who are in our master's program, that means they're specializing in treating women with compound and bioidentical hormones, they are very knowledgeable about how to augment just the right amount.
Mm-hmm.
So we don't push a woman into too much estrogen, progesterone, testosterone. It's only when we push a woman into too much that her brain, hypothalamus, pituitary is going to go, wow, there's too much estrogens floating around here, for example. Maybe we can turn down the ovaries some because we don't want to deal with excessive estrogens. Or maybe we'll increase the sex hormone binding globulin. Well, that's another interesting subject to bind up this excessive hormones.
Yes.
But the majority of healthcare providers who treat women in menopause, they're not going to want to push them into excessive levels of hormones. Now, there is an exception. there is a whole way to approach treating women in menopause in which the attempt is to get the period to keep on going on forever, or restore the period in a woman who's no longer getting a period. That's a whole other subject. I'm not going to go there. Now, back to the question. This is the first time I've ever drifted, as far as I remember, from the actual question, or have given a lengthy answer. Isn't it, Carolyn? I mean, aren't you surprised? I've gone over.
Highly surprised.
I've gone over 10 seconds of answer. I know. I could see steam coming out of your head.
I think, well, with this question, I don't mean to make fun, but I was tickled by it because it was presented so well. And she's frightened that if she does take any amount of hormone, that's going to just ruin her natural hormone making powers, and she'll be dependent upon these hormones, and she won't ever be able to make her own hormones again. But isn't that what's going to happen anyway?
Good summary. Thank you.
Well, thank you.
It's gonna happen. The ovaries are going to stop. I don't know that there's ever been an exception. Maybe in the Bible there was one or two. Women who conceived in their very late years. But there's, in my experience, there are no exceptions. Women's ovaries stop producing hormones entirely. And it happens usually in the 40s or 50s, sometimes even in the 30s, and very rarely in the 60s. So that's going to happen. And then it can happen as early as the 30s. So what do you want to do about that? Well, it's the ideal time to start replenishing those hormones. And the moral of the story is just don't give too much. Give the right amount. Start with low dosages so the brain doesn't register, oh my, our usual ovarian hormone levels are being exceeded here. Well, let's protect her body. Let's increase sex hormone binding globulin, and let's turn down or maybe turn off the ovaries. So the moral of the story is augment. It's great to intersect with a woman in a perimenopause when she's starting to have symptoms of decline. It's an optimal time to do it. It's not the only time, but it's a wonderful time to do it. And just don't give so much. Right. If her ovaries like this amount and she's declining, we'll just give her extra to bring her up into the zone. We're not going to try and push her into excessive amounts. And that's ideal for her body. She won't drop a beat. And I can't tell you how many women we meet up with. They haven't had hormones for 3 years. They haven't had a period for 3 years. They're dealing with low energy, low libido. Can we get that libido back? Yeah. Not too easily. Can we get that vagina back to decent health? Yeah. Pretty, not so hard. Can we get the bones back? Can we stop the bone loss that's occurring with low estrogens? Yeah. We can at least stop the process, and sometimes we can even replenish bone health, restore bone health. But I want to tell you, it's easier in the beginning. The earlier, the better. Let me just repeat, libido. Women don't like the loss of libido for the most part. And yeah, it can be restored. Can we get the hair back? How about the hair? Yeah, not too easily. So that's why I make a case for when the first signs of insufficient hormones start showing up in your 30s or certainly your 40s, get on the train and find, your job is always the same. Find a provider that's really good at hormones, really knowledgeable, knows what to do and knows how to do it right. If they do it right, your ovaries are still going to stop producing. For example, there are many women who we put on hormones in the perimenopause. They're still menstruating. and we're replenishing hormones, but it will not stop the ovaries themselves turning off. The period's going to stop even when we're replenishing hormones in a perimenopausal woman who is menstruating, and we're giving her some additional hormones to make up for the losses that she's had. That will not prevent the stoppage of her period. Her period's going to stop. She's going into menopause.
It's coming.
Can't stop that train.
Right, exactly.
Now, it is possible, and this is something I absolutely do not agree with, except in rare exceptions, and there are rare exceptions. I am absolutely not agreeing with giving sufficient hormones to keep that period going or restore a period. Because by my own testing on 24-hour urine hormone tests, in order to keep a period going or to restore a period, you need between 3 and 8 times the upper limit of normal, not average, the upper limit of normal of a 20-year-old's estrogens to do that. Now, the providers of that method, I have met up with the providers of that method. I presented them with the testing, and at least the last time I presented them with how much it took, they didn't want to pay attention to it, and we had a non-civil, non-optimal communication stream in person on more than one occasion.
Right.
Story for another time or never. I don't know if they are still realize that what it actually takes. Now, when you tell a gynecologist how much estrogen it takes to keep a period going, well, I've watched a woman gynecologist attending a lecture of those who were saying, let's keep the period going. And she saw the dosages that were being recommended at a seminar. She leaped out of her seat, walked over to the microphone, interrupted the speaker, and was outraged. She said, the levels of estrogen that you're suggesting there are outrageous. No young woman has ever seen levels of estradiol like that. It was quite a dramatic moment in one of the seminars I was attending.
And then someone followed her, I remember.
That's right, another doctor
right.
who was very familiar with dosages. A dear friend of mine, he got up right behind her and said, these are outrageous dosages. How can you do this? But I'm drifting. Oh my God, I don't think I've ever drifted before, like I was saying. But I guess I did drift. The moral of the story is, what I recommend is that you start replenishing to decent hormone levels, not youthful. We don't need you to be at youthful levels. In fact, we make a strong case for not being at youthful levels, but decent hormone levels to protect your bones, your hair, your skin, your vagina, your muscles as these declines are occurring. And it will not stop nature. You will stop menstruating.
Right. And so we can take these hormones the rest of our lives, correct? Because she does say, and then they're just going to make you stop them anyway at some point. And I will.
Right on. Thank you, Carolyn.
No, you're welcome.
Yeah, who's the they? They're going to make.
I don't know.
We know who they are. The Women's Health Initiative in 2002 scared, incorrectly, women and physicians all over the world away from hormones, and they have not recovered. Even though in the original study it stated that the increased risk for breast cancer was statistically insignificant, and by 2006 that same study committee knew there was no increased risk of any kind. And in 2017, the same study committee that put out the WHI printed a study in the Journal of the American Medical Association, JAMA, where they had done the original study, saying that after 18 years of follow-up, there was no increased risk. And this is even with Premarin and Prempro, no less. Premarin was always less risk, and Prempro was too. So, but it scared everybody. And since I do this as the only thing I do professionally, and I encounter women who've gone to their physicians, and the physician said, you can't take these hormones your whole life. You got to take the lowest, at best, you got to take the lowest dose for the shortest period of time. That was an invention. So women are still getting scared. So she's concerned that they are not going to treat her. But as of today, you can find thousands in the United States alone of healthcare providers, physicians, nurse practitioners, PAs, and prescribing compounding pharmacists who are extremely used to treating women in menopause with compounded bioidentical hormones. And they'll gladly treat you for your whole life because they know this. They are up to date on this information. They have kept wonderfully abreast of what the science was in the beginning and what it is. I remember talking to my pharmacist in 2002 and saying, God, man, did you see what that Women's Health Initiative? He said, yeah, but let me point out to you the weaknesses in the study. This is in 2002, right? He said, this study is so lame in there. It's statistically insignificant, even in their own study. And so there was folks right out of the gate that knew that Women's Health Initiative was foul, but they were rare. It took someone with the savvy of my compounding pharmacist to really know the details. And there was probably thousands of compounding pharmacies all over the country who knew exact details, as well as those of us who were prescribing already with compounded bioidentical hormones. Well, we'd like to congratulate Dr. Rosensweet on another very brief answer.
Well,
did I get it, Carolyn?
You actually did. You actually did. It's an excellent question, excellent answer, and I think will definitely behoove the questioner.
I think what I'd like to say, one more thing, just to repeat, I want to give you my very best shot. And just to let you know, I know a lot about hormones. Oh my God. 25 years of specializing and 50 years of doctor. And this is what I take every single day, along with a few other things. This is my compounded bioidentical testosterone. And will I ever stop taking it? Well, there's folks out there who say men are at increased risk of prostate cancer if they take testosterone. That's been the lousy, wrong, medically incorrect, but generally prevailing opinion in the medical community for decades, based on false information. Well, there's many, many living experts in this, and the ones that I respect point out that men who take testosterone are at less risk for prostate cancer than men who lose their testosterone. All men lose their testosterone sooner or later. Will I stop any day that I'm on the earth? Heck no. And I recommend that to women. Get on the right hormone dose, get on the optimal hormone dose, read our book. You'll learn what that optimal dosage is and take it every single day you're on the planet Earth. And talk to some of the most knowledgeable people in the field. They're all going to say the same thing. It isn't just me wildcatting here. Dr. Bergson has been on our show. I've had the privilege of interviewing her. Ask her what she thinks about it. Ask my 79-year-old patient who's still having intercourse and playing golf what she thinks about the hormones.
Yeah, so anyway, I'm right there with you. I am. I'll go ahead and move it into question number 2 now, which is back to what we were talking about in the last interview, which has to do with cortisol. So the questioner is saying, thank you for addressing cortisol. May I ask you again, please, how it is you address both high and low cortisol?
Another excellent question.
Yeah, these are good ones.
Let's take high cortisol.
Okay.
Extremely rarely, but I have had one patient in 25 years, since I started doing 24-hour urine hormone tests, that had a tiny adrenal tumor, or shall I?
Uh-oh. Dr. Rosensweet is frozen for a minute. I'm going to try and figure this out. But anyway, the name of his book is Happy, Healthy Hormones. And yes, you can contact Dr. Rosensweet for a consultation. I will get with you after the interview. Now I've got to figure out how to get back on the interview where he's frozen. So sorry, you guys. Hang on a sec. I don't know where Dr. Rosensweet went. Let's see. Can you guys hear me? It's like magic.
Yeah. Sorry, folks.
Yeah, sorry. Okay, I think everybody can see us now. So the question that I hope they link together somehow, but anyway, question
It's
was
like magic.
Yeah.
Uh-oh.
Sorry, folks.
Yeah, sorry. Okay, I think everybody can see us now. So the question that I hope they link together somehow, but anyway, question
It's
was
like magic.
Uh-oh.
Sorry, folks.
Yeah, sorry. Okay, I think everybody can see us now. So the question
How about now?
Okay, hang on. Let's see.
I think we got it.
I don't know.
I hear you. Can you hear me?
Yeah, hang on.
I think you can just proceed because I think we have it. Oops.
Me?
Yes. Can you hear me?
We have been around the world. It's like crazy. Okay, so back to question number 2 and high cortisol.
Yes. Thank you. That
You're
was the
welcome.
question. High cortisol and low cortisol. And I started talking about high cortisol. Rarely, and I mean rarely, and I mean really rarely, there's a tumor in that adrenal gland that's putting out excessive cortisol. It's called an adrenal adenoma. Most of them are benign. They need to be removed. That's very, very rare. The most common cause of excessive cortisol, and it is very common in younger folks, is unskilled response to the stress in one's life. The medical diagnosis is called getting bent out of shape by the stress in your life. I just invented that medical term. I don't know if they're going to give
It's in the Merck manual.
for it. I think it is.
Bent
Bent out of shape. Yeah, because if you think you're getting attacked by a saber-toothed tiger and responding physiologically as if it was a saber-toothed tiger to whatever issue you're having, you're going to put out extra cortisol. That's going to be at the vanguard of the stress response. And it's common to see excessive cortisol levels in younger folks, usually, because if you keep doing that day after day or week after week, or you go through a real rough time, and the adrenal gland will no longer be able to keep up with putting out those high cortisol levels.
Right.
And you'll get tired. And when we do 24-hour urines on women in the perimenopause or menopause, almost always we see reasonable levels of cortisol, not excessive levels. Occasionally we see rather robust levels in the perimenopause and menopause. These are the women that I'm only testing them in the menopause. Occasionally we see fairly robust levels in women in early menopause, but we don't see humongous levels. And I know salivary testing will pick up some cortisol levels getting high at night. You won't mind them during the day. You might even like them, but you're not going to like high cortisol levels at night. It's going to cause trouble. It's going to keep you awake. It can give you mood issues. And that happens, but it's really a stress response thing. The biology of your stress response is reacting as if there was a saber-toothed tiger running around your living room, rather than cash flow issues. Yeah, who likes them? Or relationship issues, or job issues. Yeah, or kid issues. Really important stuff. But there is ways that you can acquire information and tools and support so that you don't trigger an excessive output by your adrenal glands of excessive fight or flight hormones, at the vanguard of which are cortisol. That's how you get high cortisol levels, outside of that rare tumor thing.
Got it.
Do we try and stop those biologically? No. Is some people using some nutritional supplements to try and get what is a high cortisol output at night? Yeah, there's some supplements being used. I was never successful being able to switch that nocturnal elevation, but it is very possible to lower your excessive cortisol output by acquiring skills that relate to your emotions in your mind and your life, which are extremely valuable for you being able to live this life and navigate through your relationships and your jobs and the challenges of this time in a way that's more present and more successful, and you communicate better, and you don't trigger your adrenal glands to pump out these huge hormone levels, which also include adrenaline. No picnic.
No.
So that's excessive levels, and they are common. But women in their menopause, by that time, most women are sitting on the lower end of the corticosteroids, cortisol, etc., because they've had excessive stress. and most men too. Now, when the cortisol is so important in our body, it's the most important hormone that we put out. It's so important that if we don't have it, we don't get to live. We don't get to stay on the planet. That's not true about losing every other hormone you can name, including thyroid.
Yeah.
Because thyroid, you may be in bed, but you're not going to pass away. But low cortisol, you don't live. It's called Addison's disease, and the cortisol must be replenished. But these low hormone levels to that degree are very uncommon. Addison's disease is very uncommon, relatively speaking. And there's good treatment for it. And it's easy. John F. Kennedy took cortisol. He had Addison's disease. He took cortisol. And very, very easy when you're in the hands of someone who really knows how to replenish and really knows how to test for it. 24-hour urine hormone testing, may I repeat, 24-hour urine hormone testing, you get to know exactly what the corticosteroids are. When I say corticosteroids, I mean cortisol, cortisone, and 3 principal metabolites. That's how you get it right. And you can get it right, and that's for super low. Now, going into menopause and testing women in menopause, every so often we'll see some real low-end corticosteroids. What does that tell me? That woman went through a period of stress. I'll ask her, ever been stressed in your life? And I'll hear some hair-raising stories. Human life, I understand, is challenging. Oh, yes, I've had my own, believe me. And we'll see low-end corticosteroids very commonly. And when we see low-end corticosteroids, man, we're going to see very low androgens and low estrogens, because the body can not only, for fight or flight challenges, produce cortisol and adrenaline, which it does. It also can recruit estrogens, testosterone,
Right.
royally. So much so that most women entering the perimenopause, not all, but most, they're entering with low androgens. They've already depleted their androgens because they've had excessive stress. And again, the body's going to preserve the corticosteroids as the last bastion of the resources needed to produce estrogens, androgens, etc.
That's wild.
A lot of women, even though their corticosteroids might be on the lowish end of things, when they go into menopause, we will not treat with cortisol, because we will commonly, almost universally observe that if we treat with the proper levels of estrogen and testosterone and progesterone and thyroid if need be, we'll watch the corticosteroid levels recover all on their own. They will not need the cortisol. Now, rarely we'll see corticosteroids so low that we know we're not going to be able to help this woman unless we also replenish the corticosteroids along with the other hormones. And we do it in concert with all the other hormones, very often thyroid as well. But we got to keep our eye on those women that we're replenishing cortisol with, because those adrenals are going to recover. And we don't want to get them into excessive cortisol levels. We don't want to suppress their adrenal glands, as was the segue from that first question you asked me. Can you suppress my ovaries? Well, you can certainly suppress the adrenal glands. We don't want to do that. So those women that we are putting on cortisol, we're testing them every 6 months. And what we'll see is their corticosteroids are going to rise back to normal, in which case we taper them off the cortisol. And the longest I've ever had to go was treating a woman for 1.5 years who had been on cortisol long-term, long before I met up with her, because her adrenal glands recovered, and we got her off the cortisol, and I've been treating her now for, hello out there, we know your name starts with an M. I'm not going to say it out loud in case you're watching. It's been decades since we had to give this wonderful dental hygienist cortisol, because we test her every year and she's always, her corticosteroids have recovered. So low cortisol, do a good menopausal program, and you're going to watch those corticosteroids return all on their own. And in rare cases, the corticosteroids are just going to be too low. And we're going to want to start a woman off in menopause, not only with the ovarian hormones and usually thyroid hormone as well, but also some cortisol. But we limit that cortisol. We're keeping an eye on it. We don't do it for an excessive amount of time.
Thank you. Thank you for that. due to our little glitch, I'm not sure how this is going to go. So I am going to go straight to a question that I wanted to, I don't, okay, well, anyway, I'm going to go straight to a question that I was going to lead out to our ending with, and I will rearrange it for Tuesday, because I know what day it is today.
I wonder if we want to save that question, because I'm seeing what you're seeing, that there's no one in the chat.
Right, so I'm not sure.
Kathy, we see you, Kathy.
Yes, Kathy's here for sure. I don't know. So I don't know what's going to happen, but I certainly.
Maybe we should save that one, Carolyn,
Okay.
for next week, because it's such an important question. And so many women have this question. I know what one you're referring to.
Yes, and I know you do know, and I'm happy to start off with that question next week. Hi, Deborah. Thank you for letting us know. Well, then let me continue on. So if this is the second part of that last question, if a woman has a uterine fibroid, even though very low, is postmenopausal, but still low in estrogen and the other hormones, is it okay for her to still use Biased along with balancing the other hormones?
Yet another excellent question. And this questioner obviously has some information about fibroids.
Mm-hmm.
And fibroids are these benign tumors, for those of you who don't know, that show up in the uterus.
Are they like polyps, kind of?
No, they're sort of more solid, and polyps are often more of a cystic type.
Thank you.
But they're benign. They're totally benign. And even though they may grow when a woman is younger, they'll often shrink when her hormone levels drop. And what causes them? This is the real question. Mm-hmm. And I can tell this questioner has an idea about what causes them. Mm-hmm. And it's overstimulation of the uterus by excessive amounts of estrogen.
Interesting.
Not balanced by progesterone, because a woman's peak estrogen output is when she's 20.
Right.
And then it gradually declines. And you don't see many 20 or 30-year-olds with 20-year-olds with fibroids. Here's how you can get overstimulation of estrogen in a declining estrogen environment. Estrogen is exquisitely balanced by progesterone.
Mm-hmm.
However, and you can read this in the book, and someone asked, how do you get to the book?
Right.
Maybe you'd explain that, Carolyn, how to do that.
Oh, yeah. I'll take care of it.
And because progesterone can decline earlier and more profoundly than estrogen.
Mm-hmm.
Even though a woman's peak estrogen levels is 20 and she's gradually going to decline, her progesterone is also going to decline, but oh my, it can decline earlier and deeper than the estrogen. So it's not there to balance the estrogen. So you get estrogen overstimulation of the uterus, and that, we believe, is the most prominent cause of fibroids. Excessive estrogen. Excessive estrogen in a declining environment. Well, number one of the things we try and point out in the book is for a woman to be able to identify when her progesterone is getting too low and no longer balancing her estrogen.
Mm-hmm.
Because she can, even with over-the-counter progesterone. My favorite is very precisely given progesterone in our organic oils mix, but over-the-counter progesterone exists. And young women should be getting it. And how do you tell? I'll give you an example. You got a 25-year-old who's been regularly menstruating, precisely, doesn't even think of her hormones because everything's working just perfectly. And then she becomes 30 and she's getting a few surprises. She had PMS when she was 14, uterine cramps, heavy periods, but that went away when her hormones regularized. And here she is, 32, and she's getting uterine cramps again and PMS again and even some breast tenderness. There you go. That's the sign of estrogen dominance. And she's no longer, even though she's got less estrogen than she had when she was 20, she's got much less progesterone, not enough to balance that estrogen. And she's getting symptoms of overstimulation of estrogen. Estrogen stimulates that uterus. That's how you get the cramps. So that's when you want to pick up on that, and you want to be treating with progesterone. It's perfect. It's an ideal time for a woman to discover progesterone. Oh, we're not frozen. Good.
No, we're not. No, I'm frozen because I'm literally.
And that theoretically will prevent the formation of uterine fibroids, period. And it's a great thing to prevent fibroids. It's fantastic, because when you hear about all the hysterectomies to your right and to your left and all over the internet, and so many of them are caused by these benign tumors that interfere with the uterus. They interfere with menstruation. They can even get so large as to get uncomfortable. So many hysterectomies are done because of these fibroids. So, ta-da! Please discover progesterone at the right time when you're young. Give yourself some progesterone. What an amazing effect it could have on the lesser hysterectomies that will ever have to be performed because of fibroids. Why I'm thinking this question is so profound is we can do such profound good by women realizing that at an early age they should be taking progesterone, most of them, because of this thing where progesterone will decline earlier and more profoundly than the estrogen, not balance the estrogen. She'll get symptoms, and one of the outcomes of that imbalance can be the production of uterine fibroids that can lead to hysterectomy. You know, who in the heck wants to go in for an operation that you could prevent totally? How many of us love to go get into a doctor's office, realize, oh my God, we need an operation. Oh, thrill. And then, God bless hospitals and doctors and gynecologists who know how to do these, because sometimes they're so necessary, it's unreal how necessary they are. Necessary. But if they were preventable, which they are, most of them are preventable, just get into progesterone early on in your life. Read that in our book, Happy Healthy Women's.
Happy
progesterone. Take progesterone, become a friend of progesterone, and start thinking about it in your 30s.
So we're talking about progesterone, and this questioner, though, is saying that the woman is postmenopausal, low in estrogen, low in the other hormones, but can she still use, sorry about the cat, can she still use Biased along with balancing her other hormones?
Well, if she's in menopause,
yeah,
her estrogens and her progesterone are profoundly minimal. Way not enough to protect her bones, her vagina, her brain, her arteries, And absolutely, yes, she can take Biased. In fact, young women range in the amount of estrogen they put out. Some young women put out these really robust, rich levels. These women have signs of this, but they're perfectly normal. Other women, they don't need so much estrogen. They come in, so there's a range of how much a young woman needs to have regular periods, get pregnant, have normal body size and breasts and bones and everything. In menopause, you need this much.
Right.
99% of women need this much. There's a rare amount that need rich levels. 99% need this much, less than any young menstruating woman. So we're not replenishing estrogen levels that are going to stimulate fibroids, but the main way we're not going to stimulate fibroids is we're rushing in there with progesterone right out of the gate, and sufficient to balance that estrogen, like nature designed.
Yes, like
so
nature.
Yes, you can take Biased, but be sure that you balance it. Well, anyone that you're going to be able to get a Biased prescription for is going to prescribe progesterone.
Yes.
They know this stuff.
Yes.
They know how important progesterone is, and you're not going to walk out of there with a solo Biased prescription.
Right.
Although there are women that are getting patches of estradiol.
Exactly.
And so
a question did come up stating my Biased prescription states apply once a day, but I get a headache. Can I split it twice a day?
The only thing we recommend, and you'll read it in our book, as far as estrogen application, is twice a day.
Right.
We believe that the proper way to take Biest is twice a day. Biest, twice a day, period. Now, when you say you're getting a headache, this brings up other questions. Yes, it could be from too much and that one blast that you're getting because of once a day. But it can also be from too little estrogen. So if it relates to hormones, I mean, there's a lot of causes of headaches. But my guess is the questioner has gotten this down to this is related to the Biest. So absolutely split it to twice a day. That's the only thing we recommend in the menopause method is twice a day Biest. When a woman slides into taking it once a day, as often happens, just out of convenience, we'll correct her and we'll say, no. Back up on your Biest, take it twice a day, split that dose. That's the proper way to take it.
Right.
If it was easy enough to take it 4 times a day, I'd do that. But it's not, and it's not necessary. Twice a day is great. When you say headache and you relate it to the Biest, yes, you could get it from getting an excessive blast by taking it all at once. But I don't know how many milligrams per milliliter, how many milligrams you're actually taking. So it could be from too little estrogen, or it could be from that blast. So try splitting it and see if that prevents the headache. But if you still have headache, there's some dose adjustment that may relate to insufficient Biest. So headaches are a whole nother story, and getting these hormones properly balanced is a whole nother story. But yes, start out by trying it, splitting it into twice a day. And if that alleviates your headache, bravo, that's the proper way to take it anyway.
Thank you. And it's going to be great because these questions for Tuesday are pretty amazing already, on top of the other questions.
And once you know, I have a hard stop exactly on the hour.
Okay,
but
so
you might try it. Let's wing it. Let's see if
I'm gonna see if you can do this.
All right.
Is testosterone cream okay?
Now, of course, in all the times that we've been doing this, there might be 100 right now. I've never answered a question. I'm not proud of that, but I've never answered a question.
But you're always interesting, so it's just fine.
Is testosterone cream okay?
Yes, testosterone.
Here's the short version. Cream comes to you in strong solvents. I love our method. We deliver testosterone. In fact, here's a testosterone prescription. Oh, this is for males, much stronger. In a certified organic oils base, there's no solvents in there. So creams, not a fan of creams. But testosterone should never be given orally. It can hurt the liver. There's a lot of people taking it by injection. I understand that, but who in the heck wants to inject when topical testosterone works beautifully? And for a lot of men as well, even though we need much higher dosages. Topical testosterone is beautiful. Plus, it more copies nature because you're doing it every day. And that's the way your ovaries did it. They didn't do it twice a week, as again, some injections are being done, or once a week. I don't like that method at all. And who the heck wants to inject when topical testosterone works fabulously? How do I know that? Because we measure testosterone levels, and any man who got low in testosterone and then starts taking testosterone knows that stuff is absorbing beautifully. So cream, no, I like the organic oils, but certainly if you can avoid injections, and I'm not saying you never, especially for men. Women, I can't think of a reason in the world why you'd want to inject.
Yeah, you're right.
And you got to watch out for testosterone because people get high in those injections, but they're using excessive levels. That's a perfect recipe for hormonal trouble if you're getting excessive levels of any hormone that you can name. These things are too strong. Hey, what about that, Cameron Shapiro? What about that?
A very interesting interview day today. The menopause method sort of blooper day, and that's okay. Happy weekend to all. Thank you, Dr. Rosensweet, so much. Now, I know for sure today is Thursday. I know. I looked it up.
You looked it up. Yeah. And I want to pause and thank you, Carolyn, for providing this amazing forum. And when we met you, there was 1,000 women in ins and outs of menopause, and now there's much more. So,
well, that's much important.
I thank you very much for being the inspirer of the menopause, of the ins and outs of menopause.
One day
I'll see you on Tuesday.
I'll
see you on Tuesday, as usual.
Thank you for saying thank you. Thank you to the women. Thank you to you. May we all feel well, have a safe and happy, wonderful weekend. And we'll have great questions for you on Tuesday. Hopefully we won't freeze. And we'll get through it.
All righty. Bye-bye.
Adios.